With that, I want to go on to our agenda, and we have two bills for consideration. And so the first thing that we need to do is to have a motion to bring up the sub A2 on Senate Bill 4, telemedicine.
Mr. Chairman, I move that we indefinitely postpone Senate Bill 4 sub A and bring forward Senate Bill 4 sub A2.
Is there a second?
Second.
All those in favor, do we need a roll on that? I guess we should do a roll on that to the clerk.
Senator Bell.
So I want to start by discussing this very briefly because we've had a lot of discussion on this. I think that this
Senator Bell, in order to appropriately discuss it, I want to get the sub A2 in front of us. So,
well, I want to discuss the motion to amend the bill.
Yeah.
So we are able to discuss that motion, if I may. So I want to say, I want to commend the chairman for all of his work on improving this legislation. I think that this new version is a substantial improvement. There are several things I would still like to see, but one of the things I think is really important is that it does provide a compromise in terms of payment parity. I still
believe we should bring up the sub A2. We're getting into discussion of the sub A2 as you're discussing it. So I'd like to go ahead with a motion to bring up sub A2 so we can talk about it in the context. We should discuss it once it's brought up.
I do feel that once we pass the motion to do this, this actually amends the bill. So I think my motion is about, I would like to discuss the amendment that we're making to the bill.
Yeah.
And, we are able to discuss.
Senator Bell, I'm not asking to pass the sub A2. I'm asking for us to bring it forward so we can discuss it. There's a motion and a second. The clerk will please take a roll.
Senator Bell, your vote.
I'm going to vote for this motion, but I do feel like it's being presented that we can't discuss a motion, and that's not how our rules work.
Well, you started discussing the bill, so I wanted, in the bill, we will discuss with the A2 in front of us. So could we continue, please?
Senator Calkin.
Yes.
Senator DeMario.
Aye.
Senator Golden. Senator Golden.
Aye. Did you hear that?
Yep.
Senator Lawson.
Aye.
Senator Paolino. Senator Valverde.
Yes.
Senator Miller.
Yes. Senator Bell, let me present the bill based on with the sub A2. I want to go through some of the important points of it. And we've all been briefed on what the telemedicine legislation does. All those aspects remain, including allowing patients to receive telemedicine services at home, permitting the delivery of telemedicine by audio-only telephone, requiring that deductible co-payments or co-insurance are no more than if the same service were performed in person, requiring that prior authorization, medical or benefit determinations, and utilization review are no more stringent than if the service was performed in person, requires that the Rhode Island Medicaid program covers telemedicine services, and authorizes OHIC and EOHHS to promulgate telemedicine rules and regulations. The sub A2 changes the when a clinically appropriate language to now saying medically or clinically appropriate, preserves the current executive order, and this was clear based on all legal determinations that an emergency executive order overrides legislation, even if as recent as this bill, if it passes, would pass, that the emergency executive order would override the legislation. But as much of the language in the A2 and the previous bill does take the challenge to present to people some issues that just needed to be clarified, that didn't necessarily need to be law. And this is one of the things we explicitly did in the A2, was explain to people that all of what happens in the executive order is not superseded by the legislation. And once the emergency order ends, the provision will remain in place until OHIC revises the provision based on recommendations provided by a newly created advisory committee. So the created advisory committee, with much of the discussion we had previously on this legislation, we had anecdotal discussions about other specialties that may or may not be appropriate for parity. And so what the additional language allows for is entities other than the Office of the Health Insurance Commissioner, including the Health Insurance Advisory Council, the Attorney General's Health Advocate, EOHHS, and the Medicaid Office, to look at the data that is also required by the legislation to determine, rather than anecdotally or by advocacy, in a structured environment, what other specialties should be brought up to parity before there is a rate determination that happens annually, usually late spring, early summer. And it also requires that in-network primary care and behavioral health providers are still required to be reimbursed at rates not lower than when the same service is delivered in person. And the data reporting I already went through. It exists for not only, it's expanded to Medicaid and commercial, and from all the insurers to provide the data. And it also requires Medicaid to report any savings experience in government-funded programs due to expanded access to telemedicine, such as medical transportation and childcare. So now I believe probably Senator Bell wants to initiate discussion under the A2.
Yes, but first, I want to express my concern. I was going to be speaking in favor of an amendment and commending the chairman on the work he'd done on the amendment. I felt it unnecessarily hostile to try to shut down debate on an amendment.
It's just appropriate. I'm not trying to be hostile. I'm trying to explain to you that we can't have a discussion on the legislation until the legislation is before us, and the legislation that before us is appropriately the A2. And we can't have the discussion that you're very anxious to get to us without having the legislation in front of us.
So I want to discuss the motion to replace the sub A with the sub A2, which is a motion to amend the bill, which is a motion I believe that can be discussed. So anyway, I'd like to proceed with this, but I do want to express some concern. I found that unnecessarily hostile. So I do want to commend the chairman for his work on improving the legislation. I think that we have made some important improvements in the legislation, specifically to advance and create a compromise on payment parity, to allow a possibility, basically to allow us to assume that the initial system for the duration of the state of emergency is that there will be full equal reimbursement for telemedicine. After the state of the emergency, then the default assumption will become equal reimbursement, with state regulators being able to separate out additional categories that will be reimbursed at less. That's not perfect, but it does mean, I think, hopefully, that we won't see entire categories such as physical therapy or reproductive health care or emergency medicine cut out whole cloth, which would have happened under the original bill. So that is a very substantial improvement, I think, and I want to commend everyone who's worked hard to get us here. I think that's a big step forwards. I do want to still express some concerns and reservations, echoing the testimony that we received from RIPIN, the Rhode Island Patient Information Network, Emily Boucher, who's been an activist around healthcare and specifically reproductive healthcare, the Protect Our Healthcare Coalition, and then we also got a letter from, or I got an email from a woman by the name of Jill Brody. And they all seem to suggest that there should be a definition placed on the term clinically appropriate and medically appropriate, that to use these terms without definitions creates possibility of confusion. And RIPIN also noted that the removal of some of the guardrail provisions in the previous version before we amended it was not, those guardrails should be replaced. But I think the most important thing is that these terms be defined so that we not have a term that can be abused by the insurance companies. And I'm hopeful that we will be able to move forwards by possibly looking at following through on their suggestion to take the same bill and just define these crucial terms, because having definitions can really improve a law. But yeah, I do think this is a really important improvement. I suggest that we pass this out onto the floor today. And I do want to thank everyone who worked so hard to improve this legislation.
I just want to make one comment. If we could have one definition that covered all of medicine, I would agree with you wholeheartedly that we should have definitions in here about what is clinically appropriate, what is medically necessary, and what is the language that we substituted in here, which is medically or clinically appropriate, which was an endeavor to try to get some of the confusion about those things. And the reason there isn't a specific definition is because it varies almost case to case. And it is a gray area, but it's a gray area for a good reason. Clinically appropriate, as we had discussions, those of us who were involved in the OHIC meetings that led up to the initial legislation, that clinically appropriate is more often used in behavioral health situations where that there might not be a medical necessity for a therapist to quickly get on for a second call, but there might be a clinically appropriate. And so there is a case-by-case determination to be made, which can't necessarily clearly be defined. And also the medically necessary goes into both protecting consumers from and providers both from somebody being directed toward telemedicine when it would be inappropriate. Like one of the conversations we had earlier today as I was discussing this legislation was like one of the things we see possibly coming when we convene or others convene to talk about what other specialties might go on to be parity. Without seeing the data, and the reason we have primary care and behavioral health already there is because the data was there even before the pandemic, that these were inadequate, there was an inadequate network for both of those categories, right? And that was very quickly proven by the utilization of telemedicine through the pandemic. The data will be there based on the data we request in this legislation. And one of the things that might become clearest faster are those specialties that are historically inadequate in Rhode Island. So to use the case that was used in a call earlier today, dermatology, inadequate network in Rhode Island, right? but what would be considered medically necessary is based on the service provided, right? So it would be totally medically inappropriate for a dermatologist to take out a mole, to mail, to FedEx somebody the surgical equipment to remove the mole on their own, right, and observe. Everybody agrees that would be medically inappropriate for telemedicine. But the follow-ups would be, and therefore trying to put a definition in that would cover all of medicine and all of behavioral health could create barriers to care instead of being specific to care. And that's why we didn't try to do that, but we tried to add the flexibility of what you see in the legislation in the A2. And there have been gross misinterpretations of why we use one language versus another, medical versus clinical, and why we can't get more clear about what we do in that, and why we are historically confident based on what OHIC now uses to keep consumers protected on the definitions that they historically have used based on the specialty in which it should be applied to, on why consumers should feel protected currently and going into this transition when we eventually come out of pandemic conditions and emergency order conditions. Therefore, I think this is totally appropriate in the way we've added different language into this currently.
So, through the chair, if I may follow up on that, or?
Yeah. Go right ahead.
So, just quickly, so I understand what the chair is saying about the difficulty of having an overly specific definition. But I do think that the definition that RIPIN proposed, which is that medical or clinical appropriateness, quote, means the suitability of a particular means, medium, modality, technology, or location for the provision of a particular medical, behavioral health, substance use disorder, or other healthcare service or set of services based on generally accepted practices and treatment protocols, is still a fairly broad and general definition. So I think that there's an ability to define this a little bit more carefully without running into the problems of overly specifically, for instance, suggesting specific conditions and things like that. I think that there's a middle ground, and I think that RIPIN's suggestion is a good one, that we can have some additional definition to help clarify this a little bit. But also, I understand, and I think we all understand, that a definition that is extraordinarily specific and prescriptive with no flexibility could create some problems. But the suggestion that RIPIN makes is, I think, a very reasonable one, and I think it is consistent with the guidelines that the chairman outlined around the need for some flexibility in the definition.
I think I'm totally willing, and so are other people who have looked at this legislation, willing to look at an amendment that doesn't create barriers, that would potentially be a definition that doesn't get in the way of the concerns that have been presented that I tried to explain.
Excellent. Thank you, Chairman.
Yeah. Any other questions from the committee? Senator Calkin?
Thank you, Mr. Chair, and thanks again to everyone who's been working so hard on this. I was really happy to see that the most recent sub-A or A2 does not include the restrictions for things like physical therapists and other specialists. So I was very happy about that, and very happy to see that it also is attempting to limit the insurance companies from defining what services can be covered. So I did have, as I read through it, I did notice at least, I stopped counting at about 6 or 7 times that medically or clinically appropriate was used throughout the bill. And I do have some concerns, and I received the same emails that Senator Bell did. And I was wondering if there's any chance that, we could take a look at the AMA's description of what medically necessary is, because it does include clinically appropriate as part of that definition. And then maybe potentially replace all those different locations where, it's clinically or medically appropriate or medically necessary, or and different variations of that, to be just very clear about what is medically necessary.
Yeah,
Has that been
I will definitely consider that, as I said, and we have two lawyers looking at this. One is on the WebEx and one is right here, and we also have, I know we have probably several insurers looking very closely at this hearing and this language, and one of them has provided a very close to AMA definition and both maybe should or shouldn't be considered as potentially an amendment, but I do want to make sure it doesn't restrict, especially in the behavioral health category, where there has consistently been a concern that when you put medical necessity into clinical services, that it can create barriers. So we want to make sure that it doesn't have an unintended consequence.
great? Thank you so much for considering that.
Any other questions? Senator DiMario.
Thank you, Mr. Chairman. I also just wanted to acknowledge the number of communications I received around, the concerns with some of the language. And I guess I just wanted to speak to the fact that, the overwhelming concern seems to be around the idea or the assumption that, of course, insurance companies would be looking for ways to prevent access to care. And so, I do just want to point that out. And I acknowledge that is a concern. I think that, as a healthcare provider myself, one of the things that I think contextually is important to note is that, the need for telemedicine existed long before COVID, will exist long after COVID. And as a provider, the piece that I was really looking for in a piece of legislation like this was to make sure that telemedicine services would be treated the same in terms of things like prior authorization requirements, utilization review requirements, that telemedicine and in-person would be treated the same. And I do think that, that this proposed amendment does that because, it speaks directly to that idea that, yes, there are determinations of medical necessity and clinical appropriateness that happen with in-person care, which is something that is often invisible to the patient. But, that providers do have to go through those review processes as appropriate. And the idea that burden wouldn't be any greater or any different for a service provided via telemedicine is really essential for me to see. And I think, the other part of that that is really important as well, that, again, I just want to speak to some of the concerns that I've been seeing, is that, there is in this proposed amendment some mechanisms for being able to check in on whether or not this change is working the way that it's intended. And so that was something else that I was really pleased to see. And so I just wanted to speak, just in support of those two components of it.
Yeah, I think it's an important point to make in that, and maybe I want to have us talk to OHIC about whether there's a generalized definition that will at least give clarity if we put it in the legislation as an amendment without creating barriers, just as guidance to the public, because a lot of what has been discussed going into this is incredibly inaccurate to what its potential repercussions are. And so if we can put a definition that just provides clarity publicly, that would be a good thing. Like almost a half a page of this 8-page bill is explaining what is already law around executive order versus legislation, right? Did not have to be in the bill except to clarify to those who are looking at this legislation how this would unfold and how they are protected throughout a pandemic. So a definition serving the same purpose, where it didn't create a barrier but created clarity without creating barriers, might be useful if it doesn't create those barriers. So if there are no other questions, a motion for passage on this legislation?
So moved.
Second?
Second.
The clerk, please go through the vote.
Senator Bill.
Aye.
Senator Calkin.
Aye.
Senator DeMario.
Aye.
Senator Golden.
Aye.
Senator Lawson.
Aye.
Senator Valverde.
Aye.
Senator Miller.
Aye. The sub-A2 has passed, will be brought to the floor. Thank you for discussion, and I look forward to further discussion on the floor. The next bill we have in front of us is Senate Bill 16, an act relating to Health and Safety Harm Reduction Center Advisory Committee and Pilot Program. There is also a sub-A on this legislation. A motion on the sub-A.
I move that we indefinitely postpone Senate Bill 16 and bring forward Senate Bill 16 sub A.
Second.
Senator Bell.
Aye.
Senator Calkin.
Aye.
Senator DeMario.
Aye.
Senator Golden.
Aye.
Senator Lawson.
Aye.
Senator Valverde. Senator Miller.
Aye. So